Hi, everyone, and welcome to this week's COVID-19 office hours. We are going to go over a couple technical notes and housekeeping tips, and then we'll get right to our content today. So first and foremost, just want to remind us all that we are recording today. And so a recording of today's presentation, along with the slide content from today, and any content that's shared in the chat will all be posted to the HUD Exchange at the link that is up there on your screen right now. Just please give the team a couple business days to get that information posted. Also, if you have any challenges with audio during the webinar, we have noticed that at times phone audio can be a little bit more stable or clear for folks. So if you need to switch over to phone audio, you can do so by dialing the numbers that are both up there on your screen, and that'll be in the chat in just a moment. You can switch over at any time for that. Also, as you'll notice, WebEx looks a little bit different today, so some slight upgrades, but the chat functionality is absolutely still there and in the same spot on the bottom right-hand side of your screen. You'll see just what looks like a chat bubble. If you click on that, it will open up the chat functionality in WebEx for you. When you are opening up the chat, it should default to everyone, but if it doesn't, make sure to scroll down and select everyone so that we can all see any questions, comments, or feedback that you send in during the webinar in the chat feature. And with that, I'm going to turn things over to Norm Suchar from HUD's Office of Special Needs Assistance Programs.
Thank you so much, Natalie, and welcome everyone to our session today. We have a lot of great and little different content today for you. First of all, let me apologize. I won't be on screen today. Couldn't get the camera to quite connect, so we'll just hear my voice today. I want to introduce our presenters, and then we can jump right into our content today. So want to introduce, as you can see on the screen, we have several people from the SNAP office ready to answer your questions in the background. So feel free at any time to send us a question either about the content you're hearing about today or any other questions you may have. We are very excited to have some people from the Centers for Disease Control and Prevention to talk about ventilation for us. This is obviously an incredibly important topic and something we're all grappling with. So we'll hear from Dwayne Hammond and Steve Martin, and also have Kenneth Mead available to help answer questions. So we're very excited for them to join us today and present about this, again, incredibly important topic. We will also get our regular Centers for Disease Control and Prevention, our CDC update from Ashley Meehan. So we're very excited about that as well. We also have, I think, some very important and I think people will be happy to learn about some updates about our expenditure deadlines on the ESGCV program. So Marlisa Grogan will talk about those a little later in the program. Before we kick off our CDC update, just want to mention we will have a poll question. We'll post it a little later, but it's a little different. You won't have to go to an external link to do it. It will just sort of pop up on your screen a little later in the program, and it'll sort of be there on the side. So just want you to be aware of that, but would love to have you all respond when that comes up. So with that, I'm going to turn things over to Ashley Meehan from CDC to give us our COVID update. Ashley?
Hi, everyone. My name is Ashley Meehan, and I am with CDC's Homelessness Unit within our COVID-19 response. I'm just getting a notification that audio isn't working. Can you all hear me?
We can hear you well. You sound loud and clear.
Okay. All right. Well, I'll keep going. So hi, everyone. You can go to the next slide and jump right in. All righty. So our cases for the whole country are on a sharp decline, which is a really good sign. It reminds me of a roller coaster at Cedar Point, where you go straight up and straight back down. So hopefully it continues going down. We are at around 75 million cases, and the 7-day case rate per 100,000 people is 797. So things are slowing down, which is great news, and we're going to keep implementing all of those prevention measures so that we can keep coming down. Next slide, please. We've been keeping an eye on deaths for a little while now. We can see that the number of deaths is still increasing. And just as a reminder, I've said this before, but just to say it again, deaths do typically lag a little bit behind cases. So, we'll continue to keep an eye on this moving forward. The good news is that we're not seeing as sharp of an increase in deaths as we did last winter. Of course, any death is not preferred, but things aren't looking as bad in terms of severity right now. So that's hopefully a good sign, and that'll stay true. Next slide, please. I just want to show that we pretty much are seeing only Omicron cases right now. It's kind of hard to see, but about 99.9% to 100% of all cases in the US right now that do go up to sequencing are coming back with the Omicron variant. So we're keeping an eye on variant proportions. I know there have been some questions about, is it all Omicron, is it not? And it looks like right now pretty much everything is Omicron. Next slide, please. And that's all from me. I know we've talked a little bit about our guidance updates. Those are still in the review process in our clearance chain. So I'm very sorry that they've been so delayed, but we do hope to have them up soon. So just stay tuned. As soon as they're posted, we will make sure to communicate that with you all. But please let us know if you have any questions in the meantime, and feel free to put any questions in the chat. And that's all for me, and I'll pass back to you, Norm. Thanks.
Thanks so much, Ashley, and thanks for the update, and thank you for working on updated guidance. We'll definitely be interested when that comes out. So if you have any questions for Ashley, please type them into the chat window. In the meantime, we're going to move on to our next presentation. We're very excited to have a presentation on ventilation in buildings, something that's incredibly important for our emergency shelters and other housing programs. So I'm very pleased to welcome Dwayne Hammond and Steve Martin to talk about that. And also, I think we have Kenneth Mead available to answer some questions. So Dwayne, I'm going to turn things over to you.
All right, thank you. Yeah, some of my colleagues had some trouble dialing in. So yeah, my name is Dwayne Hammond, mechanical engineer for CDC NIOSH. My colleagues, Steve Martin and Ken Mead, been very involved with ventilation throughout the response. They had some trouble dialing in, so I may end up just going through the FAQs as well if they don't get joined in. But so this is our presentation on ventilation in buildings during the COVID-19 pandemic. And go ahead to the next slide. So I'll give an overview, just a quick intro to COVID-19 from some of the CDC boilerplate template slides. Then I'll get into some ventilation in buildings, talk about some tools to improve ventilation, and then go over some of the ventilation frequently asked questions that are on our website. Next slide, please. So yeah, just an intro to COVID-19. Next slide. So how it's spread. So COVID-19 is spread in three main ways: by breathing when close to an infected person who's exhaling small droplets and particles that contain the virus, having these small droplets and particles that contain virus land on the eyes, nose, and mouth, especially through splashes and sprays like a cough or sneeze, and then touching your eyes, nose, or mouth with hands that have the virus on them. So next slide, please. So back in May of 2021, CDC published a science brief on transmission modes, and there's a link to it at the bottom of the slide. It just goes into a little bit more detail, talking about the principal mode by which people are infected with SARS-CoV-2, which is the virus that causes COVID-19. That's through exposure to respiratory fluids carrying infectious virus. Exposure occurs in three principal ways. Inhalation of very fine respiratory droplets and aerosol particles, deposition of respiratory droplets and particles on exposed mucous membranes in the mouth, nose, and eyes by direct splashes and sprays, and then touching mucous membranes with hands that have been soiled after touching a surface with the virus on it. And two additional points in that brief are that the risk of SARS-CoV-2 infection varies according to the amount of virus to which a person is exposed, and transmission of the virus from inhalation further than 6 feet can occur. Next slide, please. So now if you'll notice on the previous slide, there was discussion of particles, aerosols, droplets, and certainly don't get distracted by the terminology. Different professions, clinicians, aerosol scientists, engineers, industrial hygienists, et cetera, do not always use consistent terminology. And so if you look at the graphic on the right-hand side, it's particles settling in still air. Time to settle 5 feet by unit density sphere. And there's something in aerosol science called aerodynamic diameter definition. It's the diameter of a unit density sphere that settles at the same velocity as the particle in question. And I think this graph is particularly helpful because it shows you that certainly larger particles, like 100 micrometers in diameter, they settle really quick. What's considered droplets in healthcare, 5.8 seconds. So it falls to the ground rapidly. But then as particles decrease in size, their settling velocity it slows down, and they take much longer to settle. So even a 10 micron size particle takes 8.2 minutes to settle, which is an order of magnitude smaller than the 5.8 seconds drop from a 100 micron particle. And you go down in size, a 3 micron particle will stay airborne for about an hour and a half at a 5 feet drop. And then a 1 micron takes 12 hours to settle, and then a 0.5 micron takes 41 hours. And so size distribution of a cough certainly has a wide particle size distribution, but really the takeaway from this graphic is that regardless of what terminology you use, droplet, aerosol, particle, if it's small enough to float in the air, ventilation interventions can help prevent its distribution and reduce individual exposure by dilution and filtration. Next slide, please. Just a quick note about prevention. Follow these steps. Get the COVID-19 vaccine as soon as you can. Wear a well-fitted mask over your nose and mouth. Stay 6 feet away from people you don't live with. Avoid crowded, poorly ventilated spaces. Wash your hands often. Avoid touching your eyes, nose, and mouth. The more of these you can implement, the safer you'll be. Next slide, please. So just a discussion about ventilation in buildings. That reference is our CDC COVID-19 ventilation guidance. It's very useful, and in that same link, you'll find our frequently asked questions. Next slide. So CDC recommends a layered approach to reducing exposures to the SARS-CoV-2 virus, the virus that causes COVID-19. And this is a nice diagram. It's the kind of a Swiss cheese respiratory virus pandemic defense diagram. It really is intended to point out and recognize that no single intervention is perfect at preventing the spread of the disease by itself. And if you look to the Swiss cheese layers, each of them has limitations, advantages, disadvantages. But the more you can implement, the lower your risk will be if you layer different prevention methods. So the personal things that affect personal responsibility tend to be on the left of the diagram, and sort of a more shared responsibility is on the right. But each intervention has imperfections, and multiple layers improve the success. For example, on the right, vaccines, certainly there's a possibility of breakthroughs, but they're very effective. Very effective layer. Quarantine and isolation, very effective layer. And so the more of these, ventilation, it reduces the concentration in the air, but certainly, sometimes the aerosols take a path that can pass breathing zones to get to the intake of the ventilation system. And the effectiveness of masks, very effective, but certainly fit and filtration efficiency affect performance. So all these layers are each individually very effective, but much more effective when used together. And certainly this diagram, the note at the bottom, it's not intended to be an all-inclusive, and these are not necessarily depicted in any meaningful order. Next slide, please. So just before we get too far into the ventilation, just to note that the SARS-CoV-2 viral particles are more readily spread between people indoors than they are outdoors. A good way to think about it is that even a light wind, 1 mile per hour wind is 88 feet per minute. It rapidly reduces airborne contaminant concentrations outdoors. Indoors, you're really relying on your protective ventilation filtration interventions to reduce the overall viral dose to occupants of the building. Next slide, please. So when reoccupying buildings during the pandemic, in most cases, reoccupancy shouldn't require new building ventilation systems. Buildings that provide healthy code-compliant indoor air quality prior to the pandemic can be improved for pandemic occupancy using less costly interventions. And there's just some guidelines to the right, the ASHRAE standard 62 ventilation for acceptable indoor air quality, the ASHRAE 170 ventilation for healthcare facilities, and then the International Mechanical Code are some good standards. Next slide, please. So beyond just code compliant minimums, there's some steps that can be taken. So ventilation system upgrades or improvements can increase the delivery of clean air, dilute potential contaminants, but it's important to note consulting an experienced HVAC professional is very important, so you don't make mistakes when trying to make improvements. And also, CDC guidance presents a list of ventilation interventions, tools in the mitigation toolbox that can help reduce the concentration of viral particles in the air. Each tool can contribute towards a reduction in risk. And so just like overall interventions in the Swiss cheese diagram earlier, even within ventilation, there's different layers. Implementing multiple tools at the same time is consistent with CDC's layered approach in increasing overall effectiveness and lowering risk. Next slide, please. So just some more details about steps beyond code minimum. Using these tools can reduce the risk of exposure to the virus and the spread of the disease, but it doesn't eliminate risk completely. So tools can be universally applied across indoor environments, but choosing the right tool can sometimes be challenging. A specific combination of tools at any point in time can change, and the building owner operator with expert consultation as needed should identify which exposure reduction tools are appropriate for each building throughout the year. Addition to buildings, ventilation improvements can be applied to vehicles, including public transport. Next slide, please. And so that was just kind of an overview of some of the tools. I'll get into more details of a few of the tools in the next few slides. So next slide, please. And I should mention that tools to improve ventilation. So some interventions that we mentioned on our CDC website are based on the ASHRAE, the American Society of Heating, Refrigerating, and Air Conditioning Engineers guidance for building operations during the COVID-19 pandemic. But the disclaimer that I would mention is that not all interventions work in all scenarios. Next slide, please. Increase the natural introduction of outdoor air. And so one easy way to do it is by opening windows, certainly when weather allows. You don't want rain or snow or heat or cold coming in. That's also increases outdoor airflows. Even a slightly open window can introduce beneficial outdoor air. But certainly do not open if it poses safety and health risk. Certainly falling out of a window, triggering asthma for those that are sensitive to asthma, and also mold. If it's high humidity outside, you can get other indoor air qualities. So certainly be strategic about when you choose to use open windows to increase ventilation. Next slide, please. And if you're not getting good ventilation with open windows, a way to increase that is to certainly put fans in the windows, but certainly placement is important. It varies with room configuration, and we even actually have an FAQ on fans. But avoid directing potentially contaminated air from one person to another. Place fans safely, securely in the window or door to exhaust air outdoors. Similar results can be achieved in larger spaces with gable fans, roof ventilators, etc. Next slide, please. Increase the HVAC system's supply of outdoor air. This is another tool in the toolbox. So open HVAC outdoor air dampers beyond minimum settings, if it allows to maintain temperature set points. Eliminate or reduce HVAC air recirculation. And this will not affect thermal comfort during mild weather, but it's, like I mentioned earlier, a little difficult during extremely hot or cold or humid weather. And it also may require consultation with an experienced HVAC professional. Next slide, please. So HVAC system recommendations. So, ensure ventilation systems are operating properly and provide acceptable indoor air quality for occupants. Rebalance or adjust systems to increase total flow to occupied spaces. During occupied hours, turn off demand ventilation controls that are designed to reduce the air supply based on occupancy level of temperature to save energy. And if it has a thermostat, you can certainly just set it to on instead of auto, which will operate the fan continuously instead of intermittently. Next slide, please. Improving central air filtration. Certainly we've been to facilities where there's been missing filters or filters don't sit well. So some of these recommendations are very important. But so if you're going to increase your air filtration, do it as high as possible, but without significantly reducing design airflow. You want to make sure you're still getting air to occupied spaces, and adding obviously more efficient filters puts added static pressure on your system and it can reduce airflow, and those filters load more quickly, so you'll need to make sure they get replaced more often. So increased filtration efficiency is especially helpful when enhanced outdoor air delivery options are limited, such as northern United States in the winter. Make sure air filters are properly sized within their recommended service life, and that's the maintenance element that comes into play. Inspect filter housing and racks to ensure appropriate filter fit and minimum air that flows around, minimizes air that flows around instead of through the filters. You want a nice seal around those. Operate exhaust fans during building occupancy. Ensure your restrooms exhaust fans are functioning, that they operate continuously at full capacity at all times when the building is occupied. And similar with the kitchen fans, operate these systems anytime spaces are occupied, and even consider operating them when space is not occupied to increase overall ventilation in the occupied building. Next slide, please. Just a quick note about portable Hepa fan filter systems. These systems provide additional air cleaning, especially useful in higher risk areas, such as your workplace medical clinics, areas frequently occupied by people with a higher risk of having COVID-19. But just to note that portable air cleaners that use filters less efficient than Hepa can also contribute to room air cleaning. You can look at the AHAM clean air delivery rate, but units should be clearly labeled as non-Hepa if they aren't Hepa, and the effect on overall air cleaning needs to be understood. Next slide, please. Generation of clean to less clean air movement. So this can be achieved using a central HVAC system or portable Hepa units. For central HVAC option, certainly it's necessary to reposition the supply air louvers, exhaust air grills, and adjust damper settings. It's easier to do with ceiling grid systems, drop ceilings, for example. So for portable Hepa units, it's a lot easier if you have a portable Hepa unit with a duct connection, and you can attach flexible duct work. It can be done with temporary partitions as well. Next slide, please. So ultraviolet germicidal irradiation. So it shouldn't be used alone, but as a supplemental treatment to inactivate the virus that causes COVID-19, especially useful if options for increasing room ventilation are limited and filtration are limited. So there are three types. The two that we recommend on our website right now: upper room UVGI systems to provide air cleaning within occupied spaces, and the second one being in-duct UVGI can enhance air cleaning inside the central HVAC system. And these are more powerful than the typical coil cleaning systems. And then the third one is still an emerging technology, so that's far UV systems. It shows some promise, but we still list that as emerging. Next slide, please. So flushing with air. So running the HVAC system at maximum outside airflow for 2 hours before and after the building is occupied, that's a good way to flush the building, certainly, though it may not be applicable for residential buildings that only have recirc options. Next slide. So just a note about costs. So tools come with a range of initial costs. We mentioned a lot of different tools here, and operating costs as well, which along with risk assessment factors may affect the selection of which tool you implement. So some of the no costs are open windows, inspecting, maintaining dedicated exhaust ventilation, disabling demand control ventilation controls, and repositioning outdoor air dampers. A lower cost, less than $100, using fans to increase effectiveness of open windows, repositioning supply exhaust diffusers to create directional airflow. And then at $500, and that's an approximate for portable Hepa systems. Certainly you can find ones that are much cheaper than that, as well as some that are much more expensive than 500, so that's just an approximation. And similarly with the upper room UVGI, $1,500 to $2,500, and that's just an approximate. Of course, that depends on many factors, room size, and ceiling height, etc. Next slide, please. And so now it's the ventilation FAQs, and I don't know if Steve Martin, have you had a chance to join yet?
Welcome to Hvac. Press 1 to be connected to your meeting.
Can you hear me, Dwayne?
I can hear you, Ken.
Okay, I just had a weird message. So I'm going to be Steve today.
Can everybody else hear Ken?
Sir, Ken.
Yes, you're coming through loud and clear.
Great, great. So that's not what I wanted to share. I want to share my screen. I'm going to stop my video. And if you let me know when you see my screen. Can you hear me?
Yeah, hi, this is Ashley. I can only see the PowerPoint that says ventilation FAQs.
Yeah, I'm not sure we'll be able to do screen sharing here. Micah, do you have any sense of whether we're going to be able to make that work?
Yes, just one moment. Thank you. All right, Kenneth, you are the presenter now. If you click the button share at the bottom of your screen, and then if you're trying to share a screen on one of your windows, select the appropriate window for your monitor, and then at the bottom right-hand side of that menu, click share.
All right. So you're sharing now? You see my screen?
I see your screen, that's correct.
And I just changed to a different web page?
Ventilation and buildings, summary of recent changes.
Fantastic, fantastic. So it looks like we're okay. So this is a web page. I wanted to do a little bit of a deeper dive. I'm going to be pinch hitting for Steve Martin today, but we're going to do a little bit of a deeper dive into what we call the FAQ portion of this particular page. I think I saw in the chat where you had been provided this link previously. So I'm going to jump over to the FAQ, and what we tried to do was to go into a lot more detail there. Part of these FAQs were driven by the kind of questions that were coming into CDC, ventilation-related questions. And more importantly, I want to probably scan down. All of these are potentially important to you, but what I want to come down here in particular was we have a conversation about the use of a HEPA filter and how to select one. And in particular there's something called the clean air delivery rate. We don't have time to go into all of that now, but the instructions or guidance of how to pick a filter unit are there. And so if you are looking at portable HEPA units, the way to determine which ones to get and how to position them, that information is in that FAQ. More importantly, perhaps, though, we've received recently in the last week or two a lot of input coming from the field from different entities who are engaged in doing ventilation improvement proposals. And what they're finding is that in some regions, they're being denied proposals that utilize ultraviolet germicidal radiation. This is also sometimes called germicidal ultraviolet, GUV. And it's with a misunderstanding that's out there that CDC does not recommend the use of this intervention. So we wanted to take a time or a moment today and just emphasize that upper room ventilation certainly is an intervention that CDC recognized as effective, and so we would not. Our recommendation would be that such an intervention, if it's appropriately designed and sized, not be denied. It is a technology that CDC supports. Similarly, an appropriately designed induct system is also. So we kind of talk about the UVGI in general, and Dwayne talked about it in his presentation, but also in the different types of ultraviolet UVGI, what types are working or what types are known to work. You can see there that CDC has had a guidance document out since the 1980s in regards to using upper room UVGI, and that was initially applied towards tuberculosis, but I can tell you that SARS-CoV-2 is a heck of a lot easier to deactivate than it is for tuberculosis. So we know that now at this point in the pandemic, and so I would not be concerned about an appropriately designed system that use that technology. Other ways to apply UVGI though are in duct. And it's because the airflow is really fast in the duct, it requires a much stronger bulb, and so the designer needs to know what they're doing. But if you can identify a reputable designer who's done in-duct installations previously, probably their most experience is going to be in healthcare applications, but not always the case. Then you'll be getting somebody who knows what they're doing. We have heard stories and have actually laid eyes on situations where somebody was selling a little tiny box with a blue bulb in it, right? And they said, oh, well, this is UVGI treatment. That's not the case. A UVGI system is going to be significant. You're going to know it when you see it, and a little tiny box that's put in with your fan system, whatever, is not going to serve that purpose for you. So if you have any doubts as far as what you're looking at, you can always contact us to find out whether it's a known UVGI treatment or whether it's what we would call an emerging technology. Dwayne talked about and the other problem too is that, I'm sorry to jump around here. The other thing with UVGI is that you're really disinfecting the air. And so sometimes the applications that have come in have confused air disinfection with surface disinfection. So if you're using a UVGI system in upper air or in the ductwork itself, your intent is for air disinfection. And so that probably needs to be clarified in your applications. Dwayne talked briefly about far UV. Far UV is an exciting technology, but it is still an emerging technology, and some things still perhaps need to be polished in that regard. So I would consider that. And so I use that phrase emerging technology. And so what do I mean by that? And if you look down at our FAQ number 8 on that page, we talk about that issue. And CDC as a government entity has to walk a fine line, right? We can't say, yes, use that product. No, don't use that product. And that's really difficult when it comes to emerging technologies, because we know you all are being hit with a lot of salespersons representing a lot of products, some of which probably work great, others maybe not so great. And how are you supposed to know the difference between the two? And so we talk about the emerging technology concept. These use ionization devices, some variation of hydrogen peroxide, chemical fogging, and so we have some recommendations on some questions towards the bottom of this FAQ, which kind of helps you decide whether or not, is this something that you want to invest your resources into or not. And again, we have a kind of a fine line to walk, but we can identify if you need assistance as to whether, is this an accepted known technology that's on the CDC list of identified interventions, or is this an emerging technology that's going to require me to do more homework? There's other FAQs on there, but I think I'm not going to go through each of them. You can see them and they may inspire your own questions, but at this point, I think we're ready to stop and just switch over to any questions and answers that might be occurring.
Thank you so much, Dwayne and Kenneth. Great content there and a lot of stuff that for us to think about. We're not always the group that is expert in ventilation, so this is really helpful for us. Can I just ask a couple questions? So, what would be a good way for we have a lot of emergency shelter programs. Is there sort of an easy way to tell whether an emergency shelter has, with large congregate spaces, whether it has adequate ventilation? Is there any sort of test or sort of easy way to tell when somebody should really, call in a professional and get their ventilation assessed more seriously?
There's not easy, perhaps, but there are some things you could do with one of the ways that we assess areas is, and we would probably do this when the room is empty, preferably, but we would release theatrical fog. You can get the theatrical fogs like you see people use sometimes as Halloween decorations, and you can release that into a room and see how quickly does your ventilation seem to dissipate that fog and remove it from the room. Generally, in most areas, we kind of know whether or not we have whether or not you have good airflow in a room, or at least you know when you have bad airflow. Let's put it that way. There is a handheld version of that theatrical fog generator that you can also get, so you can test different areas. If you're worried about this gathering place in the corner, for instance, is this a dead air spot, you can release that. We call it tracer smoke, but it's really a water-based fog, and you release that fog there and find out if it's what happens to the air there. Does it move quickly, or does it kind of sit and hang? Other than that, you're really kind of required to probably do some measurements. There are some things you can do with your supply and exhaust louvers. You can use a small piece of tissue paper at a supply or an exhaust louver and find out, is there enough airflow moving there that you can see it move the tissue paper. And I know early in the response, some people up in New York were doing this, and they were ridiculed in the press, but it really is a legitimate way of knowing whether or not you have airflow moving through a vent.
Thank you. Also, thank you for giving us all permission to do those fog things in our buildings. I'm sure a lot of people will be very excited about that. So we had
the one thing
question.
Can I jump in?
Please go ahead. Yep.
The way you phrase that made me realize I need to throw a caveat out. Talk to your facilities people and make sure that you're not going to be activating a smoke or fire alarm system when you do that. In most cases you will not, but you just touch base with them and make sure. I have never set one off, and I've been using them for decades, but it's worth an ask.
Great caveat. Thank you. So we have another question about, for facilities that have to cohort to do isolation. So in some cases we have, when people are symptomatic or COVID positive, we don't have, individual isolation spaces for them. So some shelters are creating sort of congregate isolation spaces. What should they be thinking about or considering when setting up their spaces with respect to airflow? Are there different considerations? How should they be thinking about that?
Well, every scenario is going to be a little bit different based on the number of people and the configuration, the size of the room, and so forth. But the most protective airflow you can generate is going to be what we call directed airflow. And so if you could imagine yourself sitting in a hallway and the air starts at one end of the hall and it blows past you and it goes out the other end, and then it goes to get filtered or goes outdoors, that's the most protective ventilation, because you're never allowing the same germs to sit around in somebody's breathing zone. They're moving out. Now that's not always a practical thing that you can apply in rooms, but sometimes it is. You can put supply arrays, for instance, down the center. If you had a room where you had multiple cots or beds, and you could put supply down the center and then have multiple open windows, for instance, that had exhaust fans in them, or even if you didn't have fans in them, but a preferred approach is to put a fan in an exhaust window. Or if your returns were there at the perimeter. So you got that airflow supply that starts at the center corridor and then goes out in each direction simultaneously towards the individuals. Put up some separating partitions that make sure they're not so tall that they don't interfere with the fire sprinkler system, if there is one. But if you could set up some separating partitions to kind of help that airflow go in the direction you want it, that would be good as well. And then the other part is strategically placing your Hepa units, if you're using portable Hepa systems, to also generate that what we call clean to less clean airflow dynamic.
Thank you. So just not to simplify this too much, but we're trying to get the air to move away from congregate spaces. So if you have a congregate space, you don't want a fan blowing air in through the window. You kind of want it blowing out through the window to help sort of, move air out away from those congregate spaces.
Yeah. So, almost every scenario has an it depends answer, but the ideal situation would be if you had windows on both sides, then you could put fans blowing out on one side, and then you had the other side open, and so the makeup air would come in on the open side and it would go out on the fan side. And so to the extent that you can approximate that, the best you're going to be.
Great. Thank you so much. I am sure that that our audience has some better questions than I have here. So I definitely. Oh, I did have one other question. The earlier one of the first slides about sort of particle size and settling rates and things like that. So what are we talking about with COVID? Obviously, the actual COVID particle is really small, but it's embedding itself in sort of what size droplets? Is there sort of a standard way to think about that, or is that could it be essentially embedding itself in any size particle?
So, for the most part, when you're thinking about human-generated aerosols that are going to become droplet nuclei, you're really looking at the 1 to 3, 1 to 5 size micron. Granted, there's data in the press or in the literature that talks about the actual virus being much smaller, but as you I think we're mentioning, if that virus is generated in the air through a cough, a sneeze, or whatever it is, there's other things there with it. It doesn't ride the air naked. It rides with mucus and saliva and salts and other stuff like that. Mm-hmm. So in terms of an aerosol of concern, we're looking at that 1 to 5 micron size range, which is kind of a relatively easy size to filter. There will be bigger ones, of course, but they will drop out of once you get above the 10 to 50, they'll drop out of the air fairly quickly.
Got it. Okay. Thank you so much. This is an incredibly helpful presentation. If you have any more questions for our air filtration experts from the CDC, please feel free to go ahead and type those in the chat window. But we will, in the meantime, move on to our next presentation. So I want to turn things over to Marlisa Grogan. She's going to talk about a letter we sent out, that HUD sent out today, and what it means and how it affects ESGCV. So Marlisa, I'll turn it over to you.
Thanks, Norm. Hi, everybody. We have the good news for some, or the relieving news, that HUD has decided not to recapture any funds from recipients who don't meet the March 31st, 2022 ESGCV expenditure deadline. So if you are not anticipating that you'll meet that March 31st deadline, you can be assured that we're not recapturing if you don't meet the 80%. We are, however, continuing to work with those recipients who did not meet the September 30th, 2021 expenditure deadline. If you are an ESG recipient who hasn't met that 20% deadline by last September 30th, then you would have received a letter and contact from your ESGCV CARES Act desk officer. So we'll continue to work with you through that process, reviewing spending plans, and we should have more news on that soon. We are also considering whether or not to implement a later deadline, which would be in place of the the March 31st, 2022 deadline for expending 80%, as well as the new overall, a potential new overall expenditure deadline in place of the September 30th, 2022 expenditure deadline. So that is still under consideration, and an important note that to make any of those changes to establish an alternative deadline for either the March 31st or the September 30th, that would have to be done via a notice, which we would post on HUD.gov. So the best way to keep informed is to make sure that you're subscribed to the HUD.gov, the SNAPS program information listserv, and the HUD Exchange listserv, and just to continue to check back on the website every so often. Those are one of the main methods of communication, but we've also notified local HUD field offices, so you may also receive word from your local HUD field office or our TA provider if you're engaged with the TA provider for assistance. So if you have any questions, please reach out to either the HUD Exchange Ask a Question portal, or you could always reach out to your CARES Act desk officer or field office. Next slide, please. So if you are an ESG CV recipient, you can take a look at this table to see where you fit in to the overall breakdown of where people are with expenditures, or I'm sorry, actual draws as of January 28th, 2022. And you can see that we have only 5 recipients at this point that have not drawn anything. And we're at 61 who are still under 20%. The majority or the biggest bulk of recipients in the 20 to 40% drawn range, and then increasing all the way up to over 80% drawn, where there are 9 recipients. And then just a note before I turn it back to Norm that as of last Friday, we are at $1.37 billion drawn, and that makes up about 34.5% of the total $3.96 billion that's part of the ESG CV allocation. And with that, I look forward to reading your questions in the chat, and we'll follow up with those, and I'll turn it back to you, Norm.
Thank you so much, Marlisa. So we have a couple questions. I do want to spend some time and make sure we're clear about the implications of all this and what this means. So please go ahead and type in your questions. And if you do remember a question later on and want to reach out, definitely reach out to your CARES Act desk officer or reach out to the AAQ. We'll obviously also be talking about this in future office hours. You know, we just sent out the letters, you know, a couple hours ago, I think. So if you should have received a letter and you didn't, also please reach out to your CARES Act desk officer. If you'd like to be notified of any, you know, developments like this, as Marlisa mentioned, it's really helpful to be subscribed to the listservs. So please go ahead and do that. So we have a couple questions here. Some of these have been answered in the chat, but I want to sort of call them out just to be sure. So one question was about whether communities or recipients that do not meet the 80% expenditure deadline in March, so we've said that we're not going to be enforcing that, but will they have to submit a spending plan or anything like that, even if we're not planning to recapture funds? So Marlisa, can you talk about what, are they going to have to submit something, or is there anything they're going to have to do to sort of trigger this or anything like that?
No, this is just a decision. In the ESG CV notice, HUD has the discretion to decide whether or not to recapture funds, and the decision has been made for the March 31st deadline that we will not be recapturing any funds for specifically related to the 80%. So if you have not met the 80% by March 31st, we won't be recapturing funds related to that requirement or not meeting that requirement. And you do not need to submit a spending plan or do anything else, make any notifications to HUD. It's just sort of self-implementing, I guess you could say. We're just not going to recapture funds as part of that requirement.
Great, thank you. And so we don't have a question, but I think it's worth reiterating. There were some recipients that got letters and submitted plans regarding their 20% expenditure deadline for September 2021. Does this new guidance, new policy affect them in any way?
So we're handling the September 30th, 2021 deadline completely separately. So those notifications have gone out to recipients who have not met that 20% expenditure deadline, and so you know the letter would have notified you that you were non-compliant with that requirement, and in that case we were asking for spending plans, and we'll continue to reach out about any potential recapture and reallocation of those funds. So that process is underway, and it's going to continue as it's set out, and then any other future changes to actually establish new deadlines, we would have to do that via notice. So, so if any changes like that happen, you'd be forewarned in notice form.
Great, thank you. Obviously, I do want to sort of insert the caveat here, or not a caveat, but I want to ask people to continue trying to use funding as quickly as possible in the most smartest, most strategic, most beneficial way for people experiencing homelessness. Obviously, you know, there are so many challenges we've been facing during COVID and with all the various different kinds of funding available. And we know communities have had to make really difficult decisions and have had very strained capacity to be able to sort of administer everything that's happening. So we very much recognize that and appreciate that, and that's really the reason we wanted to communicate this decision. But also, you know, the work does continue on trying to house people experiencing homelessness, trying to keep them safe, trying to do all the things we have been, you know, working on for the past almost 2 years now. And we definitely want to encourage you to continue. We also want to partner with you and help. So please feel free to reach out if you're struggling with expending funds, or you're struggling with how to decide how to be strategic and smart with your funds. Definitely feel free to reach out to us. We're happy to have the conversation and to provide some assistance to make those decisions. Or if you have any other questions, please definitely feel free to reach out to us. So with that, I think we've addressed all the questions we've had in the chat window. I want to thank our presenters very much. Thank you to our partners from CDC. You all are always outstanding and provide us incredibly useful and timely information, and have really been just an outstanding partner throughout this. So definitely want to thank you all, and want to thank everybody from our TA world and from the SNAP staff who are just making all this stuff work seamlessly. And want to thank you all again. I know everyone's quite exhausted, and you know, this has just been incredibly challenging, and everyone's also, I think, you know, as a community, we are very ambitious with respect to our ability to make a positive difference on homelessness, and this epidemic has really sort of, you know, challenged us all. And again, I just want to say how much I admire how well people have persevered throughout all this, and just recognize that. So thank you all. I want to wish you all a great rest of the day, great weekend, and that concludes the webinar.